And today, my guest is Erin Wright. Erin is a psychotherapist, supervisor, consultant, coach, and educator in Seattle, Washington. She completed training in MDMA-assisted therapy through the Multidisciplinary Association for Psychedelic Studies and has trained and experience in ketamine-assisted psychotherapy. Additionally, Erin is co-president of the Northwest Alliance for Psychoanalytic Study and serves on the board of the International Forum for Psychoanalytic Education. Erin, welcome to the podcast.
Yeah, thanks for having me.
And today, Erin will be our guide into the vast world of psychedelics.
Hold on.
Yeah, that's maybe setting it up a little bit more broadly than we mean. So I don't know, dial me in a little bit. What are we going to talk about today?
Yeah, I'd love to talk a little bit about MDMA and MDMA-assisted therapies and what all is going on with that, and just a little bit about what's going on with psychedelics and how is it impacting and shaping the future of mental health.
Great. Yeah. So listener, if you popped on this episode hoping for a bit of a trip, sorry. Instead, we're going to be talking about the recent clinical applications of psychedelics in the world of mental health treatment and care from a psychotherapeutic perspective. And that's what we're here for.
Yep.
Very exciting. So listener, a peek behind the curtain. I ask my guests to write an outline. I actually give them homework, which is very cruel of me to do, I know. But you might have noticed, listener, if you've listened to the show, I ask people often some version of what got you interested into this. And that was actually the first bullet point in your outline was all theory is autobiography.
All theory is autobiographical.
So what brought you to psychedelics and specifically psychedelics and their psychotherapeutic use?
Well, I guess first I should say my whole life, I have been very anti-drugs. I grew up an athlete, went to sports camps, grew up in the era of Nancy Reagan and DARE. So that worked pretty well on me. I was scared to death of any of that stuff. And I carried that with me through my life. I played basketball in college for a couple years. You can be randomly drug tested at any time during that. And throughout my therapy career, at one point, I found myself working in an emergency department at Valley Medical Center. One of my favorite jobs I've ever had. And I really saw a lot as far as how drugs impact people and what was going on in the community. And I would say during the time I was working at Valley, probably our main problem at that point was methamphetamines.
Sure,
Fentanyl hadn't quite come into the supply in the way that it is now. But that was another point where it was like, oh my gosh, drugs are bad.
Yeah.
I don't want anything to do with this. And then during COVID, when all of our lives changed, I had started reading a little bit about some of the research that was happening with psychedelics and just kind of thought that's really, really interesting. And then I had someone I was working with, a client who was exploring psychedelics and came in and started kind of talking about what they were experiencing with it. And I was really struck because it was the first time I had heard about a substance being used for personal growth, kind of in a way to access different parts of ourselves, to think about things differently. And I was really astounded about some of the things that client was experiencing. And it was almost like when they talked about their experiences, we had talked about a lot of stuff in their therapy. But the way he was talking about things, it was almost like they got it. Like something had moved from cognitive down into affective experiencing, which I think is really what we try to get to so much in therapy.
Yeah. I just want to point out a couple things for the listener, especially if you're not a psychotherapist. You're talking about, there's two things you've mentioned already that I think any practitioner listening to this will feel very familiar with it. And Mom, this is for you.
Yeah. Great. Awesome. Yeah. So important.
Yeah. The two things are, first, just the fact that your story is that a client brought this into you. If you're listening to this and you are a client of psychotherapy, know that you are the reason why your therapist is good at their job. And actually research bears this out, right? Our training doesn't really make people better therapists. Level of education, number of years practicing doesn't even really make people better therapists. this is now beyond the research. This is personal theory, but I think the thing that makes people better therapists is deeply intimate, transformative encounters with the other.
Mm-hmm.
And when you're open to the ways that your clients are changing, especially outside of your like influence,
Mm-hmm.
your own worldview and like ability to think about people and the way you think about people has to shift if you're going to stay with them and stay useful to them.
Right.
So like the fact that that's part of your experience feels so important because we can't really talk about that super directly all the time,
Mm-hmm.
but it seems very true.
Mm-hmm.
Like I have multiple things that I kind of am known for as specialties because I had clients early on in my career who showed up with those things in my office.
For sure.
And I was impacted by it. So I just want to highlight that very broadly as like a, hey, if you're listening to this, curious about how psychotherapy works, the clients are huge to every psychotherapist's personal development.
Definitely. And a lot of clients ask, do I matter to my therapist?
Yeah.
Yes, you do.
Absolutely. Because of this client, this is the second podcast episode you've done on this topic or interview. Like that's pretty huge. So I just wanted to note that. And then the second thing, oh no, I lost it.
It's okay. Oh, it was probably affectively.
Yeah. That
understanding
transition
something.
from like, they got it, right? Like listener, when Erin said they got it, like I immediately knew what she meant.
Yeah.
And I was like, okay, I need to note this for you, listener, is like, and likely you've had this experience too. I feel like most people have, where we can talk to someone and be in conversation with them and they can say something that's like suddenly you understand your life from a different perspective and you can think about it and it makes sense. But when you're back in that moment of stress or when you're back in that moment of fear, you continue to experience the world in the same old way. I can tell somebody 100,000 times, look, people don't actually want to chase you away. People want to love you and care about you. But in their moment of stress and anxiety, when they've had a fight with their partner, they're going to still feel like they got chased away. And one of the like holy grail of like psychotherapeutic treatment is the moment where someone goes from understanding a thing to living a thing. It's not just feeling it, it's living it. And what I was hearing you describe was that transition.
Yes.
And affect is a word that we use in psychotherapy to mean emotion, but it also means a full embodied experience of a way of being.
Yeah.
So I just wanted to hallmark those things.
Great. Thank you. Thank you for doing that. Yeah. Yeah. And so it really was that experience. And then I had been talking about that some in my own therapy. So alongside that, at the same time that was happening, so I've been in therapy for 15 years. I cannot imagine being a therapist without being in therapy. I'm sure it will happen at some point, but
yeah, most people get there. But
yeah, most people get there. That's not average for everybody. People don't get freaked out by that. And I have done a lot of really great work in therapy over the years that I am very proud of. And I have also, throughout that work, hit periods of struggle still that were really hard for me and could really like derail my life in ways that wouldn't be great for me or the people around me. And so like, even though I'd made all this great progress, I kept hitting these bumps. And so I've been talking to my therapist about this. And my therapist one day comes in and says, you know, have you thought about psychedelics at all? And, you know, I'd also been talking to my therapist about this client. And so it wasn't like completely out of the blue. And I was like, oh, that's an interesting thought. And, you know, she didn't recommend it, which I think is an important thing to note because of the legality of it right now. But what it led to was me eventually finding some people to work with for myself, and had my own experiences with MDMA that really, I would say, changed my life in really significant ways. So yeah, that's my road. And I thought, man, like the potential this has to impact folks in a new way in the realm of mental health. And don't get me wrong, I believe so much in psychotherapy and the healing power that can happen in a psychotherapeutic relationship. I do think that we need more than just talking as well, too. And so I had some really impactful experiences with that really shaped me. And then started just getting really interested in all this stuff. And I think you'll find that's a story of a lot of people who are really in the psychedelic field and interested in this work too.
Yeah. There is more than talking is what's needed. That is absolutely true. I feel like that's an open secret in a lot of spaces. Like every now and then you'll get someone who's really dogmatic, who's like, no, you can just talk about things and then everyone will get fixed. But I feel like that's rare. I feel like most people, most therapists know talking about it isn't enough sometimes and often. And like for human society, like inside an individual mind and outside of an individual mind, there is some need for something more very often. Okay, let's talk a little bit about the history of like the legality stuff.
Yeah.
Because I feel like that's pretty important.
Yeah, totally. Yeah. So psychedelics were actually legal for a long time. There's a lot of research being done in the 50s and 60s, primarily with LSD, with psilocybin. That was kind of referred to as like a golden age, if you will, of psychedelic research. And then things started getting kind of out there during the Nixon era and Vietnam War and Timothy Leary and all that stuff. And not that what was happening was bad by any means, but the Nixon administration really started kind of seeing what was happening with psychedelics, and it became part of what they called the counterculture at the time. The Vietnam War was losing support and popularity. The way I phrase it is that it's opening up people's minds to how messed up everything is. And that became a threat, I think, to what was happening going on in that period. And so the Drug Enforcement Administration was formed and things started being scheduled and outlawed. And I can't remember the exact date, but things were shut down almost overnight as far as the psychedelic research goes. And I truly believe if that had not happened, I think the way we would be practicing mental health care now would be different than what we're doing right now. To do MDMA, that actually was not outlawed until I believe about into the 1980s, mid-1980s, 84, 85. So it was legal. You could go to a bar and get a tab of ecstasy with your drink at the bar. And then again, we're having too much fun. With something. And the government eventually outlawed MDMA as well, even though there really wasn't the evidence out there to make it illegal.
Interesting.
Yeah. So
like addiction risk, overdose risk?
Yeah. So psychedelics and MDMA, there is no known lethal dose for like LSD, psilocybin, MDMA, very safe drugs. Now, I say that MDMA, if let's say you take some crazy amount of MDMA, I mean, we're talking 400, 500, 600 milligrams, somebody could die from that, especially if the MDMA is extremely pure. But the reason they're going to die from that is because MDMA increases heart rate and blood pressure. And so you get into like that high of a dose of something, then, that's really, really risky.
Yeah.
But again, no known lethal dose of LSD or psilocybin. So you can't really overdose on it in a way like we think about fentanyl or opioids. Now, what you can do is you might find you engaged in some behavior that you later regret due to the hallucinatory nature of things.
Sure.
It's not like alcohol. Your body does not develop a physical dependence on it. What can happen is you can develop what we call a psychological dependence on the experience. So where you're just like so enamored with these states of mind that you just want to hang out in them all the time. And so you start kind of avoiding real life.
Gotcha.
If you will. So that's a risk as well.
Right.
Yeah.
And there's a number of things that fall into that category in my mind of the behavioral addictions. Sometimes they're called like gambling. Some people will put like sex addiction or pornography addiction in that category. Problematic marijuana use oftentimes falls into that category as well, where it's like, unlike with alcohol, you won't like experience physical withdrawals that will threaten your health if you suddenly stop. And it's more about the way you are in the world that could become problematic.
Right.
So
it's a great way to say it. Yeah.
I mostly wanted to just throw that up there because I want someone who's listening to this who might be a little skeptical from the beginning to not think we're going in with purely rose-colored glasses.
Right. No, I agree. And I really appreciate that because I think that can happen with psychedelics. There's so much hype around them right now.
Yeah.
I kind of present myself as I love these, and I call them medicines because
Sure.
of how they help people too. So I'll use that interchangeably probably, but these can really help people. I'm also what I would call a cautious enthusiast, where I think it's important to come in with like tempered expectations, where these medicines are not a silver bullet that are going to fix all of your problems.
Right.
You're not going to do one psilocybin dose and be cured of every ailment in your life. You might have a really amazing experience. You might also have a really hard and difficult experience too, and have to figure out how to work with that. And so I think a lot of people can come into this, especially with some of the clinical trial data that's coming out, is so promising.
Yeah.
Right. It's great. And we definitely need the research. Some of my critique of these trials is that the sample sizes are really small. So there hasn't been any kind of wide scale. And the reason for that is the National Institute of Health, for any other medical thing, is the primary funder of a lot of research that goes on in the United States.
Sure.
They just now issued, I believe, 2 grants for studying psilocybin for smoking cessation, but they have not been funding any of these trials. And so a lot of these trials have relied on private donation, philanthropy, or, you have a biopharmaceutical company who's might be relying on venture capitalism or something like that to fund these trials.
Gotcha.
Which is okay, but because of that, you can't run them at the large scale that we might do for a medication,
right,
or something like that. And these clinical trials are being run in tightly controlled conditions, which are great. Like, that's awesome. And that's very different than I'm going to go take 3, 4, 5 grams of psilocybin. And for those who don't know, psilocybin is the active ingredient in what we would call magic mushrooms.
Right. Yes.
And so somebody going to take that in, Discovery Park on a weekend with people around is probably going to have a different experience than somebody who is going to New York University on a depression clinical trial.
Right.
So,
yeah.
Set and setting.
all that matters a lot.
Yeah.
So I'm thinking about, there's this word that comes up a lot in all kinds of medical treatment, which is the panacea. And that's Greek for healing everything. The cure all, literally cures everything. And I think that there is a desire in most people. there's a fantasy that's really powerful of, if I find that one thing, then my problem will be fixed, right? If I win the lottery, right? When people talk about what would you do if you won the lottery, they're talking about what would you do if you had the financial panacea that solved all your troubles, right? And in the world of psychiatrics, there have been a few different panaceas that, when we get too excited about like, this drug is so powerful, it causes trouble. We've seen that with lithium. We've seen that with antidepressants. We've seen that with ADHD medication and other stimulants. It's a thing that just happens culturally. And I've actually had experiences with some clients who had other providers, prescribers, who seemed to treat psychedelics in a very sort of panacea kind of way, where they just like handed them out to my clients who were told like, yeah, go do this like every week until you feel better. And what I'm hearing you say is, it's very tempting to think and feel that way, and people get very excited. And it sounds like you're advocating for a far more measured response.
Yeah. It's hard, right? Because, I'm one of these people who has experienced how amazing these medicines can be. I've also seen how they can be harmful when not used in the proper way, or even without proper support as well. So, and I'm actually like, if it's not harming somebody, I'm not against the panacea effect.
Sure.
I'm like, hey, if it helps us feel better, great. As long as it's, not doing harm too. Yeah. And I was listening to Gabor Mate one time. I really liked what he said. I think he was talking about ayahuasca, and I'm not going to quote him directly, but basically he was talking about how in the West, we don't like suffering. We don't like pain. We want that thing that is going to take away our pain and suffering, which in a way is a natural human response. But our work really is to learn how to live with our pain and suffering versus trying to rid ourselves of it, if you will. Yeah.
So let's talk about how we can make use of psychedelics to do that, or how people are. So most of your training and experience is around MDMA. So let's start with that.
Yeah.
What is it?
Yeah. What is it? Yeah. Okay. So I'll talk to you about the model that I was trained in, and then maybe we can shift to what might happen with that model.
Sure.
So I went through the MAPS training in the fall of 2021. And I think that's just important to note as I talk about this, because as we've, you and I have talked about, things shift quickly.
Yes. Yeah. MAPS is the Multidisciplinary Association for Psychedelic Study.
Correct. MAPS is the organization. They're a nonprofit who has spearheaded a lot of the research specifically into MDMA. They also are the ones who submitted the application to the FDA for approval for MDMA. But what's important to also note is they recently, their for-profit arm, which is going to be the one bringing the MDMA to market, went through a name change to Lykos Therapeutics. So essentially, MAPS and Lykos Therapeutics are roughly one and the same. They just have different functions in all of this.
So MAPS is the nonprofit advocacy educational side, and then Lykos is the production of the drug, selling it, getting it in people's hands side.
So basically they're going to be handling the pharmaceutical side of things.
Right.
And in this country, it costs a lot of money to bring a drug to market.
Yeah.
Rick Doblin, who's the founder of MAPS and has just done amazing. I can't believe how much that guy has persevered through over the years in trying to bring MDMA to legal status. He really wanted to do this through all philanthropy funding. He did not want to take money from venture capitalists and, have a board and answer to shareholders and all of that. And did an incredible job raising money for that, but hit a point because of the healthcare system we live in and what it requires to bring a drug to market, had to eventually shift that model. And that's a whole other side road we can go down into, some other time.
I'm very aware right now just how spicy this topic is. Like, we've spent the past 20 minutes essentially couching this conversation and trying to say, take us seriously. And also, we're not cops. And also, we're not a psychopharmaceutical company shills. And also, we believe in this. And also, we know there's limits. It's like,
welcome to psychedelics.
Oh my God. How do you talk about this in a way that other people are going to listen?
Yeah, it's a very nuanced conversation.
Wow.
Yeah.
Well, we'll try to have one. Okay, so MDMA. Let's talk about it.
Okay, so MDMA-assisted therapy for PTSD involves a series of preparation sessions and medicine sessions. The model involves 2 therapists and the patient.
Okay.
There's actually 3 people on the treatment team. So that would involve your prescriber, so your medical person who prescribe MDMA and do the medical screening, and then your 2 therapists. One of those therapists has to be a licensed mental health provider.
Okay.
The other person can be a bachelor's level provider and has to have gone through the training, the MDMA training, to do it.
So why 2?
Well, because the thought
I understand the prescriber, that makes sense.
Yeah.
But
So I think there's 2 ways of thinking behind that. One, the MDMA sessions are 8 hours long.
Oof.
That is
it's a very long time.
I think very long time.
It's illegal to work that long without a break. Is that the real reason?
I don't know what the labor laws are.
Yeah,
but
it's 4 hours.
Yeah. Okay. Maybe I should remember that in my practice. No. So
if you're self-employed, all those laws.
We can.
Anyway.
Yeah. So one is just, that's a lot for a therapist, right? Like, that's a lot of stamina you have to have. And so I think from an energetic level, people need breaks. People need to go to the bathroom. People need to eat during that time.
Right.
Somebody who's on MDMA is in a very vulnerable space. And so want to make sure you're providing good care for that person. So that's one aspect. The other aspect is because patients are in such vulnerable states when they are with the medicine, the thought is just for patient safety overall, so that both therapists could be a check for each other on what is happening. Because unfortunately, things have happened.
Right.
Things have even happened in clinical trials that were not okay, and that came out afterwards. So the thought is, from an ethical standpoint, better to have 2 than 1, I think.
So kind of like the law around childcare, any official like childcare facility needs a certain ratio of adults to children. And there always has to be 2 adults in the room at any given time because children are a vulnerable population.
Yeah.
So what I'm hearing you say is, similarly, someone who's in the middle of an MDMA experience is a vulnerable person. And the therapist yes, we hold therapists to certain ethical standards. We expect them to be trained to a certain level. And the person who's having the experience is at a level of functioning where having two people there means that you're less likely to end up in a weird spot.
Right.
You've got a team.
Yeah.
And also for the stamina thing.
Totally. For the stamina thing. And I'll also say like the MDMA clinical trials were all videotaped as well. Things still happened in one of those trials too that weren't okay. But that was something that happened in Canada during that part. So that's the treatment team and the patient. Yeah. And then you have 3 preparation sessions before your first MDMA session. Those preparation sessions are an hour and a half long each. So then you have a medicine session. And then you have what we call 3 integration sessions, hour and a half each, another medicine session, 3 integration sessions, last medicine session. So that's your third. And then 3 kind of integration/ending sessions.
Okay.
So every 3 to 4 weeks, you're having an MDMA session. And then that's couched, obviously, in a lot of psychotherapy.
Gotcha. So the ratio is about 3 to 1 in terms of like sessions where you're, for every one session where you're taking the medicine, you're having 3 sessions to process it. And each of those sessions is an hour and a half long, plus another 3
at the beginning
to prepare for.
Yeah. Yes, that's 12.
So 12 total.
Yeah.
Okay, so 4 to 1.
Yeah. Yeah. You know, what comes out being FDA approved could look slightly different from that.
Sure.
I was listening to a podcast with Bessel van der Kolk. It was on Psychedelics Today, and I really loved what he said. He worked on one of the MDMA clinical trials. You know, he said, I think this model is a beautiful model. He said, I'm not sure how practical it is for our healthcare system. Because this, again, I really love the model, but you start thinking about 2 therapists, medical provider, 12 therapy sessions, 3 8-hour medicine sessions. How much is that going to cost somebody within our healthcare system? And so you think about equity and access. Who's going to have access to this?
Right.
And is insurance going to pay for it? And at what point are they going to pay for it? Are they going to want to see more trial data? Now you think about that too. I think you also have to measure that against how much money are people with PTSD paying for some sort of treatment throughout their life.
Right.
Between psychotherapy, possible inpatient, outpatient programs, you know, medications, that kind of thing.
Money spent on dissociative coping skills,
going
to the movie theater or drinking too much. Or
yeah, for sure. Yeah. Yeah.
All those other ancillary costs.
Yeah. So that's an overview of what the model they've been training therapists in.
Okay.
You know, but again, the FDA has kind of final approval on what will happen. And I think it'll be interesting. It'll be interesting to see what the FDA comes out with because the FDA does not regulate therapy.
Right.
When they approve MDMA-assisted therapy, it would be the first time a medication is approved in conjunction with therapy.
Interesting.
Yeah. So they very well could come out and say like MDMA is FDA approved when it's given in the context of psychotherapy in this way. Yeah.
Because I imagine that there are some drugs that are approved for certain procedures, right? Like an anesthesiologist isn't going to give you general anesthetic just like to take home.
Right. Yes. Yeah.
So I imagine this would be the first one associated with with
therapy.
With therapy, with psychotherapy.
Yeah.
That's curious.
Yeah.
So I am so curious to hear a bunch of things. Where to start?
Yeah.
Let's walk through it chronologically. Like, what are the preparation sessions like? Like 3 sessions, an hour and a half long each, to prepare. What does preparation look like?
Yeah. So what you're really trying to do is, in a sense, trying to fast track the development of the therapeutic relationship.
Okay.
And so you're trying to build kind of a bond of trust between the patient and the therapists because you're going into such a vulnerable space with them.
Right.
And if there are things that come up between the therapy team and the patient that really should be talked about and worked out before that first medicine session, then that would be done during the preparation sessions. Yeah. You're talking about, how's this going to go? What is this going to look like? What is taking the medicine going to look like? And then you're kind of also setting intention, helping the patient set an intention. What is it that they are really hoping to get out of this treatment?
Yeah.
And I'll say it is very important to set intentions. And then with psychedelics, it's also important to be open to gently letting those intentions go because you just don't know what's going to happen when you get in that space. And touch. So touch is a part of psychedelic assisted therapy that, depending on how you work as a regular psychotherapist, may or may not be a part of that treatment. So that's also something that's talked about, and you would hopefully practice with the patient beforehand. So like, even if it's just, are you okay with me holding your hand? Patient says yes. Okay, now let's hold hands here for a few moments and see how that feels, and see how that feels in your body. And we're going to practice that while you're in a sober state, before you get medicine on board. Because the rule is consent can be given sober. Consent cannot be given under the influence. So if it's a yes, it can become a no during the therapy session. If it's a no and then changes to a yes under the influence, we don't go back on that. And we talk about that in the integration sessions afterwards.
Gotcha. Already, this treatment model flies against a lot of like standard Western concepts of mental health and mental wellness. Like everything you're describing sounds to me to be hyper aware of the inherent like relationality of like human emotional well-being and specifically trauma recovery. Because I think you mentioned this, but I want to highlight it again. This treatment is for PTSD, post-traumatic stress disorder. This is for the sake of relieving the symptoms that come from trauma.
The legal application of this, yes, will be for PTSD. Now, I think MDMA can be helpful for a lot of things. But yes, as we're talking about it now and what will legally be approved, yes, for PTSD. There's a way of thinking about the totality of emotional well-being, but PTSD in particular, as being an individual problem that an individual person has inside of their individual mind. And a lot of what I talk to folks about repeatedly on this show, on the last show, see the episode with Karen Weisbart on the social unconscious. We talked about this a lot. This came up in my conversation with Carol Poole about using psychoanalysis to make sense of times of crisis, is that human beings are not isolated individual creatures. We are meant for community. And when you take a human being and you isolate them from other human beings, that's a form of torture. And the human being usually becomes very mentally unwell. And what you're describing is a treatment that the format of it seems to not just acknowledge, but lean into the fact that you're dealing with human animals in a room together. Like the general rule among psychotherapists, in the same way that most sessions are about 50 minutes, most therapists don't touch their clients. And like I work with kids, there are certain kids who need physical contact. It happens where it's appropriate, right? There have been times where I've given clients hugs. I feel like that's a thing most therapists have done at some point or another. But what I'm hearing you say is that this treatment involves people getting to a place where their human animal that they are needs other humans in a very embodied way that's direct. And like you have to set up a framework for that. You have to set up a framework of consent. And I will get on a high horse about that all day long, that therapists wanting to provide psychedelics really need to understand consent and how that works and what that is, and how to ask for it and how to respect boundaries and know around it. And I'm still growing in that. I'm still learning a lot more about it, but it's something I feel really strongly about.
Because that's something that like informed consent is a part of psychotherapy to begin with. And a lot of people who have been doing this for a while are aware that like you can only inform so much. Like you can describe the process to people as much as you want. You can talk about it intellectually, but kind of like we were talking about before, the difference between understanding and like that affective lived on like being a thing in a way. Doing our best at informing is very important. And especially if you have an existing relationship with someone, my gosh, I can easily see how it'd be easy for someone to accidentally, not intentionally, but accidentally coerce someone, get consent from someone that wasn't really full consent. And so taking all this intentional time and being very open to the process.
And the stakes are a lot higher when you throw in a psychedelic. Too.
I bet. So let's talk about that. What does a medical session look like? I know it's 8 hours long and you will take MDMA. What else happens?
You take some MDMA and you just hang out and groove. No. Yeah. So often a patient is laying on some kind of comfortable bed, couch, cot, something like that, and is wrapped up in some cozy blankets, often wearing eye shades, and then a pair of headphones, and we'll have music playing during that time. Often it's instrumental music, but the music does have intentionality behind it and what's curated to hopefully evoke a range of emotional experiences. So what MDMA-assisted therapy is predicated on is this idea of what they call inner healing intelligence. And we actually believe this in psychoanalysis too. I've actually seen it referred to in some of Philip Bromberg's writing, maybe not using that exact term, but what it means is essentially we all know inside what it is that we need to heal. So here's an example. Like, let's say you get a cut on your arm and you go to the doctor. The doctor will give you medicine, give you antibiotics, maybe give you some stitches, but the doctor is not directly healing that cut. What the doctor's doing is providing the right conditions for the body to be able to engage in its own healing process to heal that cut. Yeah. So the idea is the same with the psyche, that we all innately know what it is we need inside to heal. We just need some help along the way. So really those kind of right conditions to engage our own kind of natural healing process. And what's so amazing about MDMA is it really engages that because of the way MDMA works in the brain. So when MDMA comes online, it releases dopamine, serotonin, and norepinephrine in your brain, which is adrenaline, essentially.
Gotcha.
And those are a lot of feel-good chemicals. And
dopamine, by the way, listener, if you're not familiar, dopamine is the reward chemical. It's the one that says, yes, I got it. Serotonin is... Well, I did a whole episode on that with someone else. Complicated.
It is complicated.
But it's a little bit more of a long form kind of like...
It helps us feel good, too.
It just helps you feel good. It helps you feel good.
Yeah.
And the norepinephrine is like energizing.
Yes,
right?
It is. It is energizing. And so as the MDMA is coming online, it releases this in the brain. What it essentially does is it turns down the smoke screen of the amygdala. Right. Okay. And so the amygdala is that part of our brain that engages the fight or flight response. Right. And somebody who has PTSD often has an overactive amygdala, which is contributes to the hypervigilance and the avoidance of anything reminding someone about the trauma.
Right.
And so, a lot of people who are engaging in something like prolonged exposure therapy, trauma-focused CBT, that sort of thing, there can be high dropout rates in those treatments just because it's hard. It's hard to get close to those traumatic events without getting overstimulated and overwhelmed.
Yeah. So the amygdala is what controls fight or flight. And when someone has PTSD, they tend to be hypervigilant, which means they're constantly, on some level, paying attention to signifiers that remind them of the traumatic experience.
Right.
Things that are similar. That part of the brain is essentially saying, keep an eye out for that thing that hurt you. Keep an eye out for that thing that hurt you. And our brains are very good at finding patterns and are very good at making links. And those links are not always as meaningful to external reality as they are to internal reality.
Yeah.
So to use like my go-to like trauma example is a dog bite, right? So if someone gets bitten by a dog, if someone develops PTSD and becomes hypervigilant around that, they might develop a phobia of dogs. Alternatively, if someone gets bitten by a dog when they were walking next to a chain link fence, every time they see a chain link fence, they might find themselves having their heart rate increase and they might develop a bit of a panic response to things like a chain link fence. Or if they get bit by a dog that was on a chain that jingled at a certain tune, then when they hear that tone or the sound of a jingling chain, similarly. And part of what you're referring to is that hypervigilance extends to even ideas and concepts.
Yeah.
So people can drop out of some of these exposure therapies because not only because they're going back to the story and the narrative and the memory itself, but because even the act of sitting down and talking about it, the amygdala is already saying, oh, we're getting close to the big scary thing. Run the hell away.
Right.
And what I'm hearing you say is what MDMA does is essentially like take some power away from the amygdala. Ask your brain to behave in a way that deprioritizes that part that's become a watchman, that's like on the lookout, and therefore more able to approach the big scary thing.
Yeah. So yes, that's a great way to put it. And so as that happens, somebody then feels safe enough often to go back and revisit some of the trauma that they've experienced without getting into that hyper aroused state during it. So
remembering without reliving.
Yes. Or in a way remembering without reliving. Although I would say like part of working through trauma is like processing the trauma, which might feel like reliving. I think there's a way we can do that while staying in an optimal nervous system arousal, but it's really really hard to do. Right.
Yeah.
And so that's kind of the magic of MDMA, is that it helps somebody stay within that optimal zone of regulation, that window of tolerance.
Right.
Yeah.
And listener, when you hear us saying arousal, we're talking like broadly physiologically speaking. And what we mean is more or less the amount of energy in a body and a brain around a thing, right? If your brain has too much activity in it, too much energy in it, it doesn't function super well.
Yeah.
Like a brain that's and a body that's at too high of a physiological arousal state is kind of like a car or a piece of machinery that's overheating.
Yeah.
Right. Like certain systems don't work as well and might shut down completely. So the window of tolerance is this idea that if someone's not emotionally engaged enough with something, then they won't really change.
Right. Yeah.
And if someone's too emotionally activated, then
it's traumatizing, re-traumatizing.
They won't change.
Yeah.
You either won't change because it's not sinking in, or you won't change because you are stuck in those old patterns that you can't get out of, like a rut.
Right.
And what I'm hearing you say is MDMA has a tendency to help people stay physiologically, emotionally, energetically, use whatever language you want to use around that, within that window.
Right. Yeah.
And I wanted to flag up something you said earlier about the inherent capacity for healing.
Yeah, inner healer.
Yeah, that concept I've noticed is really popular right now with like the two like modalities, which are EMDR and IFS.
Yeah.
Right? Like both EMDR and IFS have a major emphasis on those two things. And that feels, and like you said, it's been in psychoanalysis the whole time, but like that feels really important. That like the healing that's being tapped into isn't something that's being imposed upon the client.
Yeah.
It's something that's being evoked within the client.
Yeah.
And that relational piece is huge though too. Because without the right relational context, without the trust in the people who are around you, without that safety, without that framework of knowing, yes, I feel comfortable holding this person's hand, or no, I don't, and we've agreed ahead of time and know it's going to happen, that inner healer sometimes isn't safe enough to come out and do its job.
Yeah, for sure. You know, in the MDMA medicine session, like it looks different than how you or I might practice therapy.
Well, I imagine so. I've never done therapy with someone wearing blinders over their eyes.
Try it, see what happens.
I could. That's true.
But really, the therapists are there to facilitate and hold space for unfolding and to provide safety. So the therapists aren't there suggesting things the client should look at or talk about or something like that. Really, it's client-led in the sense that, you know, there's a trust that the inner healer inside somebody will just know what needs to come up. Now, you know, in the MDMA training and the clinical trials, mainly in the clinical trials, because, you know, they have to develop some kind of protocol to follow.
Right.
They do in there, you know, if the client hasn't brought up the trauma that they came in to address, like, you know, towards the end of the session, the therapist will at least ask about it, like towards the end. But really, the therapists are there to hold space for what arises and then follow the client's process around that and where it goes. So it looks, there's no interpretation or any, no, you know, because somebody is highly suggestible in that state too.
Right.
It really is more of maybe a hands-off approach than what a typical psychotherapist might be used to. Yeah.
So it's like super non-directive.
Super non-directive. You do not want to be directive in a psychedelic space unless it's for somebody's safety.
Or even suggestive, it sounds like.
You do not want to be suggesting things because somebody is so in such a suggestible space.
Yeah.
You really want to follow the client's process and where it is they're going. Yeah.
There's almost a parallel here I mean, perhaps this is completely batshit, but there's almost a parallel here to like early hypnotherapy then. Like that's kind of a similar mental state that can come in through hypnosis. But with hypnotherapy, you're trying to leverage someone's suggestibility. It sounds like in this, someone's entering an altered mental state,
right?
But the therapist's role is just to like, the image I'm getting in my head is like you have this vulnerable person who's in the midst of some suffering, and the role of the treatment team is to essentially stand around them, like with one eye on the person, making sure that they don't roll out of the circle, and the other eye around everything else, making sure that nothing comes into the circle either.
Yeah, I really like that. Yeah.
Which there's, okay, oh boy, here we go. There's something shamanistic about this.
Yeah, totally. Yes.
How do we engage with that as two white people?
I am not the expert or one to talk about that. There are friends of mine, people I know who have been trained kind of in some shamanic practices.
Sure.
But that is, something, I do think that there are ways of doing this that in any of the psychedelic assisted therapies, not just MDMA, that do in a way, maybe not explicitly, but that do bring in some shamanistic / indigenous cultures. And that is a huge critique of the psychedelic field, I think, because I think some indigenous cultures feel that their culture is being appropriated in that. Another reason it's really important for therapists to be culturally aware and trauma informed and not practicing outside of the way in which, they are and exist in.
Right.
So, yeah.
Yeah. And on the other end of the pendulum from that, it feels like this treatment modality is engaging with like something about humanity that's kind of always been true about humanity, right? Like depending, there was a moment a week or two ago where I was talking to someone, psychoanalysts in particular, like to joke about how the parallels that exist between psychoanalysis and sex work, right? Because you're getting paid for intimacy, right?
Oh, okay.
And like, it seems to me that if like one of the like roots of the tradition of psychoanalytic treatment go into sex work, then the other root goes into being a priest. Like working through troubles in being through intimacy and existential and felt quasi-spiritual. And by spiritual, I mean difficult to define, things that are more felt than understood. Like this is trouble that human beings have had forever.
Right.
And we've been trying to address forever.
Totally.
And it strikes me that so many healing traditions do make use of medicines that involve psychedelic experience.
Right. Yeah.
And it sounds like that's what's trying to be created here.
Yeah. Trying to be created, but I also think is having some challenges within our Western model, because part of our problem in the West is that we are so cut off from all of that. And, especially here in America, we like rationale, we like objectivity.
Yeah.
And I think part of what kind of drives people nuts in trying to research psychedelics is you really, no matter how hard you try, I don't think that there's a way to truly get rid of subjectivity. Any researcher, you want to get rid of bias. You can't tell me any researcher is not bringing themselves, their own personal story, their own personal history into what they're researching.
Yeah.
Maybe that's different with like something like concrete, like a medicine, where there's chemistry and stuff involved. But when you get into researching, something that's subjective, like the human mind,
right?
I don't think we can remove everything.
Right.
And I will say the MDMA clinical trials, it was a double-blind, placebo-controlled trial. So what that means is neither the therapist nor the patient knew ahead of time if that patient was actually getting MDMA. The patient took the pill.
Right.
It is really hard to blind psychedelics. Whether or not you're on mushrooms or MDMA or something like that. The therapist is gonna have a good idea, It's
not like Prozac that like takes 2 weeks to kick in. Like.
Totally. Yeah. So, while it was double-blind, placebo-controlled, our subjectivity is still in the room.
Right. Right. The philosophers refer to this as the problem of qualia.
Yeah.
Right. Like you can't avoid it. It's just real. And one of the reasons I like the theories I like is because they seem to embrace subjectivity and intersubjectivity and all these fun concepts. But yeah, how do you create or how do you allow the reintegration perhaps of these highly subjective, relationally and community oriented methods of healing and emotional healing into a culture that doesn't like subjectivity, that doesn't like community, and that doesn't like what can't be predicted?
Yeah. That would be a huge challenge for psychedelics within our medical system.
Right.
I think there are people who have been working with these medicines for a really long time in different contexts outside of clinical trials or like the medical system who are bringing a lot of those things in. So it'll be interesting. You know, I believe in everyone should have access and everyone should have safe access. And I feel anxious about what will happen when these medicines are incorporated into our American capitalistic for-profit American health system.
Right.
I feel anxious about that.
Understandably so.
There's actually companies who are trying to take psilocybin and reduce the length of the psilocybin trip. And reduce, like, somehow, I'm not smart enough to know exactly how they do this, but like basically like altering the molecule in a way that takes away the hallucinogens, basically turning it into a pill you just take.
Interesting.
When it's like, you know, what might actually be healing is somebody having this 5, 6, 7, 8 hour experience with another human, being witnessed, having to work through the messiness and the hard things of all of this. Yeah. But that's not exactly profitable in our system either.
Right.
Yeah.
Hey, look, capitalism is the bad guy again. How'd that happen? Oh, well, let's hop back into it. Okay. Yeah. So someone's taking the MDMA. They're in this space. It's a medical session. What, having acknowledged that this is subjective and not objective, what is that experience like?
Yeah. Yeah. Well, it's different for everybody, but I would say...
What? Subjectivity? Get out of here!
Yeah, I know. So generally, what people experience, it's such an incredible medicine. I mean, God bless Sasha Shulgin, the chemist who resynthesized it in the United States. It creates one of the most safest and connecting feelings I think anyone will experience in their life. And there's a sense of groundedness and coming home to yourself. I think that it almost makes me cry a little bit. That one experiences while on this. It's extremely, extremely powerful. It creates a lot of empathy and also decreases judgment in one's mind. It really, really is incredible. Yeah.
It sounds like there's a lot of openness there.
Yes,
and a lot of tenderness there.
Yeah. Yeah. A lot of self-compassion.
Yeah. And I can absolutely see why it'd be important to let someone do their thing without intrusion in that kind of a mindset. Because often what I'm imagining is that one's internal capacity for healing is oftentimes a powerful but fragile thing. And I imagine that sitting back and letting that unfold can be beautiful, but
love. I mean, that's the word I think of. I think of MDMA, and you know, there's a reason the street name for it was ecstasy.
Right. Yeah. So it is an ecstatic experience. Okay. So you've gone through that. You've had that session. You've had your subjective experience. You've processed through whatever you're processing through. Is the client usually, are they encouraged to like talk about what's on their mind?
Yeah, that's a good question. So because MDMA is so connecting and relational, like people want to talk on it.
Cool.
What you're trying to facilitate though in these sessions is it is important, I think, to engage verbally with what's happening and what's going on, but you're trying to facilitate, it's a dance of engaging relationally and then also helping somebody kind of connect with themselves and go into their own internal process and connect with what's happening inside of them. And that's part of the reason we use the eye shades and the music is to really try to help facilitate that inner process.
Interesting. And, and is the client encouraged to keep those things on for the full 8-hour experience?
I mean, we're not going to like strap you down.
Right. Yeah.
Make you keep them on. I think that's really dependent on the client. Some people really like to wear them. Other people would rather have the music like outside of them. Some people might not want any music after a while. So it's really open to what is helpful for the client with that. Yeah.
I keep thinking about this analogy, so I'm going to throw it out there.
Yeah.
You know about butterflies? Try again.
They're very pretty.
Yeah. But when a caterpillar goes into the cocoon, what happens inside the cocoon? It's not a transitionary. Like if you cut open a cocoon mid like pupation period, I'm not a
botanist.
No.
Me neither.
What's the word for it?
You could say anything about it. I believe you.
Anyway, I don't study bugs, but if a cocoon is cut open, what's inside of it is not some transitionary thing that's half butterfly, half caterpillar. It's a pile of goop. The butterfly's body is made up of a dissolved and reconstituted caterpillar. Like biologically, it breaks down on a cellular level and reconstitutes. And one of the things that people who do study bugs have found is that you can teach a caterpillar that yellow flowers have food and blue flowers do not, and the butterfly will remember. And as you're describing this process, I keep thinking about the role of the therapist as maintaining the cocoon.
Yeah, totally. Yeah, that's what it is.
So deeply fragile, deeply subjective, and kind of something that you sit back and just make sure that space stays contained.
Yeah, for sure.
Yeah. And the mess doesn't spill out and no other mess spills in.
Yeah. And so somebody goes through that experience, and then the integration sessions afterwards are really more therapy in the sense of how you and I might imagine doing therapy. It's really unpacking the experience, trying to help the client make meaning out of the experience, thinking about, okay, like what might an intention be for the next session, providing a support, because while this is a really amazing experience, I call it like dredging up a lake. You dredge up a lake and all the silt is at the top, and somebody's not high on MDMA for forever. So it can be hard coming down, and the next day all that silt's still there, but you don't have the MDMA online anymore. And so it can take a while for that to settle back down. And so making sure somebody has proper support and care for what they need during that time as well.
And this sounds like it's trying to counteract the problem of what some folks have called the trouble of a mountaintop experience. Right. There's a lot of talk in various circles, especially around people who work with the category of like pilgrimage, like whether you're in a spiritual tradition or as an anthropologist or whatever, where like people will go on these pilgrimages, take these journeys, have these mountaintop experiences where you encounter something beyond, right? Something opens in you. It sounds very similar to a lot of what you're describing, this openness and there's something sublime, and it might be quite painful, but it's transformative. And then the trouble is integrating that into the rest of life. So many people have mountaintop experiences on pilgrimages, whether it's at Burning Man or at Mecca, and then
real life comes back.
They go back home and continue doing what they were doing before. So it sounds like these integration sessions, aptly named, because they're seeking to integrate the experience you've had with the way that you live day to day.
Yeah. And so really thinking about what happened during this session and say, okay, now that we're back to real life, what do we need to take from what happened in these sessions? And are there changes that you need to make in your life, whether that's in the realm of self-care, whether that's, okay, I realized like, gosh, I had some wild experience feelings in my body. Maybe I need to do some body work now. Maybe I need to re-engage my relationship with nature in some way. Maybe there's a relationship I've been in for a long time, and that relationship actually isn't working for me anymore. The rule of thumb, though, is because these are such open spaces, don't make any big life decisions. And like at least the next month or two following an experience. Because, while these are amazing experiences, this is real life. And we want to think about like, am in my sober state okay with the outcomes or consequences of these decisions that I'm making? Am I ready for that in my life?
It's kind of like how in AA, they tell you for your first year of sobriety, don't make any major life changes. Don't change your job. Don't change your relationship status. Don't move across the country. Similar idea, right? Because people in their first year of sobriety from an alcohol addiction often are experiencing the kind of like euphoric possibility that it
Mhm.
sounds like is common to experience in these MDMA experiences as well.
Yeah.
And it's a lovely thing, but it needs to be integrated well with the
Mhm.
rest of one's sense of self.
Yeah.
Otherwise, you're just being manic.
Yeah. And that's where the change really happens, you know.
Right. That feels important. Where the change really happens.
Mhm.
Where is that?
I think that an MDMA session brings up the things that we can work on. And I think it does engage that affective response. Like we really often get something for the first
Mhm.
time. And I think, you know, we do feel better. I think what it also means is that doesn't mean hard things aren't going to happen.
Right.
You know, it doesn't mean they're not going to feel pain or that trauma might not ever affect us again in a certain way.
Mhm.
But what it can shift is like, what are the different choices I'm going to make now and
Yeah.
how I respond to that? If I'm having a hard trauma day, am I going to go drink a bottle of whiskey now because
Right.
make that go away? Actually, that's not very kind to myself. I'm going to go for a walk with my dog. I'm going to call a friend.
Mhm.
I'm going to go on a camping trip for the weekend because that's going to help me re-engage my healing system.
Right.
Yeah.
Sounds like the change happens when the mountaintop experience gets lived out.
Mm-hmm. Yes. That's a
When
great
you're
way to
off the
say it.
mountain.
Yeah. Yeah, totally. It's a great way to say it. Yeah. Yeah.
And so one more question before we move on. After someone finishes this like course
Mhm.
and they've done their like decompression session, they've done
Mhm.
their 3 medical sessions, they've done their 3 like wrap up sessions.
Mhm.
Do you refer people to continuing therapy at that point? Like
I
if
think
someone-
that can be something.
Okay,
Yeah, for
yeah.
sure. Like if somebody, you know, needs to continue therapy, I'll be interested to see what happens in the legalization process because I do think there'll be people where 3 sessions aren't enough.
Yeah.
Or somebody might benefit from having 1 or 2, you know, kind of return sessions a year or something like that.
Right.
But yeah, but I do think continuing in therapy or starting, you know, some kind of therapy again can definitely be a part of the integration process as well.
Yeah.
Yeah.
So let's talk about legalization. Like
Yeah.
where are we at with this treatment model that
Yeah.
we just discussed
Yeah.
that MAPS trained you in?
Yeah. So Lykos Therapeutics, remember that's the one that's handling bringing the drug to market,
Right.
has submitted what they call a new drug application to the FDA for approval. The FDA has fast-tracked the application, and I think hopefully sometime in the fall, August, September, they'll make a decision as to whether or not to legalize this. I would be shocked if they didn't, especially if they're fast-tracking it. Once they do that, the DEA has, I think it's about 90 days to move MDMA out of Schedule 1. So Schedule 1 is the most restrictive form. Marijuana is in Schedule 1, I would just like to note, where it's considered to be highly addictive and high potential for abuse. So all the psychedelics are in Schedule 1. MDMA is, marijuana is. I don't think opioids are because they're prescribed. So they might be Schedule 2 or 3. Don't get me started. Yes.
Okay.
Scheduling is not necessarily based in science.
Sure.
And what will likely end up happening in itself is MDMA as a drug. I don't think the entire drug will get moved out of Schedule 1, at least not right now. And I hope one day it does. But what I imagine will happen is the specific formulation of MDMA that Lykos has will be the one that is placed into a medical schedule. So maybe something similar to ketamine or what opioids are in now.
Gotcha.
So they have to do that. The DEA has 90 days to do that, I believe, was what it is after that's done. The other thing, which I don't think a lot of people realize, is then you have state legislatures. And some state legislatures follow DEA's scheduling of drugs. Some state legislatures have their own kind of process. So depending on what state you're in, then your state legislature has to do that process.
Right. We're in Washington State. Marijuana is still a Schedule 1 drug, and I could buy a lot of it like tonight if I wanted to.
Right.
On my way home, there are stores where
here.
legally you can go and buy quite a lot of it.
Yeah. So I don't know how long that process will take. I don't know the drug laws in every state. So that has to happen. And then we have to think about, how is this going to work? You know, I would have a hard time doing this in a private practice setup.
Yeah.
Because I need a prescriber.
Right.
I also need a way to store a medical drug and follow all the regulations around that and how to access that. There's ways that you have to record going and getting a drug out of a safe if you're going to use it for medical things. You have to have the setup. You have to have good soundproofing. So, I think that these things will become legal. I don't know how soon this will be widely accessible to folks. We also have to look, what is the price tag going to be on this? How is insurance going to deal with this? Are they going to be willing to cover it?
Right.
So while I think we are moving along, I hope folks kind of realize like FDA approval does not mean I'm going to be able to go out and legally do it tomorrow.
Right.
The places I think that'll be set up sooner are, ketamine clinics. I honestly think a lot of ketamine clinics are really, they're doing ketamine, but they're really positioning themselves to be able to offer psilocybin and MDMA as they become legal.
Right.
They're more set up to do that. My critique of that, ketamine is a very different molecule than MDMA and psilocybin. So even though you're set up to do that, the sessions are longer. You need therapists on staff. How is that going to work within your clinic? It's not going to just be so simple as to say like, oh, now I'm going to offer MDMA.
Right.
But I do think they'll kind of have a head start on that. And then I really think the VA, that's my hope. A lot of these MDMA clinical trials, some of them took place within VA settings. The VA in Portland, Christopher down there has done some great trial work and I think is trying to get a trial started for groups with vets. And the VA, I think, is really set up well to offer this. So I hope it's offered quickly within the VA as well.
Yeah.
But it's not going to be the fall. We're all going to be able to go out and get legal MDMA.
Right. Yes. What I'm hearing you say is that the process is promising and slow.
Yes.
Just to hallmark this for the listener, we are currently recording at the end of March 2024. So when this episode comes out, I will probably
a different landscape.
Yep. Yeah. I will edit in here.
Yeah. And the other thing, too, I should note is therapist certification. So technically, I've completed training in MDMA, but I'm technically not certified.
Right.
And the requirements for certification seem to be changing. When I completed my training, it was something like you needed, I think, 40 hours of clinical experience along with 10 hours of supervision. And you could only get that on a clinical trial.
Right.
So if you had access to that and you just completed the training, there is very murky right now as to what the FDA is going to say. This is what therapists need to be officially trained in to be certified, and this is what they have to do to be able to offer MDMA. So we have to have enough providers who are able to offer this as well.
Right.
Yeah.
So I know you wanted to talk about harm reduction. So we've just talked about timeline. We made it clear there's a lot that's up in the air. It's hopeful, but the wheels are slow. Some people aren't going to wait.
People are definitely not going to wait.
To them, what would you like to say?
Yeah, because a lot of people are out there suffering, and I get I get it. So I think, whatever avenue you are interested in exploring this on, there's a few things I do want people to know. Wherever people are procuring MDMA from, please test it. Please test us. Fentanyl is a thing. Fentanyl is in the drug supply. So if you're going to go somewhere and get MDMA, there are legal testing things you can do to test your drugs. So Dance Safe is an organization. They sell at-home test kits for not just MDMA, but a whole range of drugs.
Yeah.
Completely legal. You buy it, take it home, figure it out.
Right.
The other thing is there is an actual legal drug testing lab called Drugs Data run by an organization. I hope I say their name right. ERWOID, ERWOID.
Okay.
And the DEA does allow it to exist. And I think it helps them kind of know what's out there and what's in the drug supply. If you go to drugsdata.org, you can, I actually find it a little more entertaining than like Facebook or social media. You can go in there and see people have sent in their drugs, what they think it's sold as, and then what's actually in it.
Wow.
So what you can do is you take a little sample of your drug, put it in like a capsule or something. You do have to pay for it, put some money and a piece of paper that a form they have you fill out. You obviously don't get your drugs back.
Right.
But you send it to them and then you watch and it will tell you at what point what your drug actually is. So those are both legal ways you can safely test your drugs. The other thing is, I do want to say like who this is contraindicated for, because that's really important. So MDMA specifically, this is pretty much the same across most psychedelics. You cannot take MDMA safely and be on antidepressants. Okay. So anyone who's going to do this has to be able to tolerate going off their SSRIs. And there's a risk of serotonin syndrome if you don't, which can cause death. So do not take this in conjunction with psychiatric medication ever. You have to be off SSRIs. Somebody who has diagnosed dissociative identity disorder should not do MDMA. Anyone who has a history of psychosis or psychotic disorder, and folks who have an immediate family member who has a psychotic disorder. So let's say mom, dad, sibling.
Yeah.
It's not recommended that they do. My advice to somebody who's in that situation would be wait until it's legal and there's a structure to support you in case something does happen and you make that choice to do that.
And the reason for the immediate family member thing is because so many of these mental health conditions are in fact genetic, and specifically for psychotic disorders, through lots of history of observing how drugs interact with people, certain psychedelics can tap into an otherwise not super visible or present psychotic functioning in a person and be brought to the forefront in ways that are troubling and cause trouble for somebody. Right. So if you don't have that in your subjective experience of your life, but you have a family member who does, there's enough of a risk that you might tap into something that's currently not trouble and make it trouble.
Totally. Yeah. So that bipolar 1. Also,
I was going to ask because that's the mania.
Yes.
Psychosis is.
And again, I think bipolar might be one of those that you might be able to explore legally. Right. Like, when there's more support in place, or I would love to be able to see this offered in inpatient settings one day, where somebody could go and have an experience and then have good care in an inpatient setting. But bipolar 1, and then medically uncontrolled high blood pressure.
Because of the norepinephrine.
Yeah.
That's going to raise your heart rate and raise your blood
pressure.
So
no heart conditions, no uncontrolled high blood pressure, pregnancy, obviously, and then liver disease.
Okay.
Yeah, you do not want to use these medicines for.
Okay.
There are lots of different contexts people seek out using these medicines. And I just encourage people to ask just some basic questions of anyone who might be sitting with you, keeping you safe, like during these experiences. Have you had training? And I'm going to say these questions. I don't think there's wrong or right answers to them, but they really, depending on what you're looking for and what you're wanting, you really need to feel things out and what resonates with you and what feels safe.
Through the process of asking these questions, you'll be able to hopefully be able to get a sense.
Is this right for you?
This? Is this good?
Yeah. So has somebody had any sort of training or not, either in trauma or psychedelics, therapy, mental health, any of that stuff? So training, how do they understand boundaries and consent? I think that's really, really important because there's been so much shady shit that has happened because people don't understand those things or just don't care. Yeah. So like, has anybody ever had any sexual issues with you? Do you become friends with clients? Do clients ever come live with you? That sort of thing. Important questions to ask. And then how do you deal with physical touch? Do you touch clients if they ask for it or not? But at least having a conversation around that. If somebody is providing the medicine for you, asking them like, was this tested? And then, where or how was it tested? And then, this question I say for anyone, even therapists, have you done your own work?
Right.
Have you worked with these medicines yourself? How much work have you done with them? And like, how have you engaged your own healing process in that? Because I believe this as a therapist and just in general, if you're going to be in a helping relationship with somebody, we have to do our own work. Yeah.
I feel like we could have an entire show just about this.
There's lots of them.
I bet.
Yeah.
And listener, if this interests you, I have a feeling I'll be talking about it again. So this feels like something that will become very significant. And something that's in the background of this that I find exciting and also a little bit terrifying is like the established communities of psychotherapists of all modalities are going to need to engage with how these medicines change the way that we approach mental health treatment. That was true with, the first generation psychiatric medications that saved so many people's lives and caused so much trouble. That was true with the introductions of SSRIs. That was a big part of the reason for the, behavioral revolution, depending on who you ask. It feels like I'm looking at a sea change, and I'm very curious to see how the psychoanalytic community manages that.
Yeah. And I will just quickly say, like, because you and I are both into psychoanalysis.
Yeah.
And I think the psychoanalytic community in particular is really set up well to help people with these medicines because we're already used to thinking in the realm of the unconscious.
Yeah.
And thinking in terms of maybe symbolism. And I think more importantly, these two words again, we're taught to really understand and recognize transference and countertransference.
Right.
And with psychedelics, transference and countertransference becomes so amplified. And I really think somebody needs to be skilled at recognizing that and working with it when it happens. Yeah.
Okay. I need to stop myself.
Okay.
So I'm going to for now.
Yeah.
Before we sign off, listener, absolutely, there will be a bunch of stuff in the show notes. My voice will probably come in before the credits talking about that. Is there anything that you would like to specifically call out, either just as a plug or if someone's interested in learning more, if they're feeling like I am at the end of this of like, I wish I had more time.
Yeah.
Where would you direct folks?
Yeah. I think maps.org is a great website just for information in general.
They got maps.org?
Yeah.
Wow, dang.
Check it out, man.
That's maps.
Yeah. I really love, there's a great book that came out last year called I Feel Love by Rachel Nguyen, Nuwen.
Okay.
It's a great book on MDMA and like where it's been and how we got to where we are now. And it's like not like dry historical reading, like the storytelling, and it's fantastic. So I really recommend folks check that out. I offer consultation for both therapists who have clients working with these medicines, but I also offer it for clients too, who might be working with therapists and who want to talk to somebody about trying to suss out, like, is this a good idea for me or not? I feel really passionate about harm reduction, which means like people having the information they need, like good, accurate information to make the best decisions for themselves.
Yeah.
So I offer consultation for clients and therapists around that. I have taught some classes for a couple group practices, really enjoy doing that. And then I also kind of offer more specific integration services for folks who are working, and that looks like individual or groups. I run an integration group as well.
Cool.
So people who are exploring psychedelics can come talk about their experiences, and I can do that on a short-term basis for individuals as well. I'm sure my website will be on yours.
Oh, yes.
Yes. So you can check that out.
Check the show notes for the website.
Yeah.
So it sounds like, if you are a listener and your therapist said at one point, have you thought about psychedelics? And then your therapist was like, that's all I got. I read Michael Pollan's book, I guess. Then you're the one to call.
Yeah, I'm happy to talk to folks. Yeah.
And if you're a therapist listening and are thinking saying to a client, have you thought about psychedelics? Maybe hand your card next.
Oh, sweet. Yeah. There's lots of great people in this community. I've only really been in this world since 2021. And I just, I'm not going to name specific names, but there's a lot of people locally who have had a huge impact on me in this work that I've learned a lot from, and who have really given freely a lot of their wisdom and love and information and care and holding and teaching that I am so appreciative of. And I've learned a lot from them as well. So, yeah. Yeah.
They know who they are.
They know who they are. Yeah.
Well, thank you so much for being so generous with your time and for being one of my first guests on the new show.
I'm so happy to do so.
And I hope you'll be back.
Cool. Someday. Yeah, I'd love to. Talk about this all day long. Yeah.
Listener. Once again, we have an episode where time has passed for us, even though very little has passed for you. Erin is back in my office. Hi, welcome back. And it's been most of the year. We are recording now at the beginning of December in 2024, and we recorded our episode back in March.
Yeah.
So
A lot has changed.
happened. A lot's happened, which is
happened.
why we decided to come back and record this little addendum. Listener, you've just heard our conversation about this treatment protocol that was at the time under review by the FDA, and there was a lot of stuff that was about to happen. So Erin is back to let us know.
Give you a little timeline over what's gone on. Yeah.
So what happened?
So we recorded in March, and then in June, the FDA had what's called an advisory committee meeting to discuss the data and whether or not to recommend to the FDA whether or not they should approve. What's important to know is the FDA advisory committee doesn't have final say on whether or not the FDA should approve a new drug.
Okay.
It is a group of people outside the FDA who meet, look at the data, discuss, give their opinion, and then give a vote as to whether or not the FDA should approve it. And most of the time, the FDA follows the advisory committee's recommendations. There have been a couple instances in which they haven't, but normally they do. So that advisory committee met in June for a very long time. I listened to parts of the meeting throughout the day. And
this is like a public meeting.
It was, wow. And all of them are. Anybody can listen in to them. Yeah.
Okay.
And the advisory committee voted, I'm not sure the exact number, but it was pretty overwhelming for the FDA to not approve MDMA assisted therapy PTSD. And I can't get into all the nitty gritty of all the reasons why.
Yeah.
Some of the concerns were in study design and flaws in the study design, which is ironic because MAPS worked with the FDA to design the study. So that was interesting. So flaws in study design, concerns about unreported adverse events, concerns about some medical information not being collected. Those are kind of the main things. And then always like the FDA, I don't know that they're sure what to do with this therapy component because they don't regulate psychotherapy. So there's some uncertainty around that as well. So then that happened. The advisory committee overwhelmingly said, no, we can't recommend this. And then the FDA in August voted to reject MDMA assisted therapy for right now.
Okay.
Doesn't mean it won't happen. They want MAPS, now Lykos Therapeutics, to basically do another phase 3 clinical trial. Okay. And I think Lykos is working with the FDA right now on what do they want that trial to look like. Those also take time and money.
Yeah. So part of what I'm hearing is that there was, like, when we last recorded, there was the potentiality that within a year, the model you were trained in could be a fully approved legal and model of treatment for PTSD. And that was a misfire. It didn't quite go. Now they need to do a whole study all over again.
Not the entire study. So clinical trials have different phases that they do. There's like phase 1, phase 2, phase 3. I'm not a clinical trial research expert, but most of them start with like safety and efficacy of the drug and then move forward from there. So phase 3 is basically like the last set of trials that it's the last step before FDA presenting to the FDA and FDA approval.
Gotcha.
So the FDA is asking Lykos to do one more set of phase 3 clinical trials, get the data from that, and then they will hopefully look at it again and go from there.
Yeah. Okay. And is there any sense about how long that process will take or anything?
Nobody knows right now.
No one knows.
Or I don't know, at least. There might be people smarter than me who know, but I don't know. Yeah.
Okay. So listener, for those of you who are excited about the potentiality of this treatment modality, your excitement will have to be held for a little while.
As a legal option. Yes.
Right. So let's talk a little bit about like looking forward. Like specifically, we've talked about this modality that we talked about, but more broadly in the realm of like psychedelics, particularly for mental health treatment and mental health care and emotional wellness, what does the future look like now? And just to make it explicit, like when we recorded in March, I didn't imagine that RFK Jr. could potentially be in charge of anything important in the coming years. And now we have a real wild card of an administration coming in. What is the psychedelic community gearing up for?
Yeah, I think there's so much uncertainty that nobody really knows. And again, when you say the psychedelic community, there are people all over the spectrum in the psychedelic community, from some very, very interesting people all the way to your very clinical scientist people. So nobody knows what it will mean. RFK Jr. is a proponent of psychedelics.
Right.
There have been critiques of, do we want an anti-vaxxer associated with this treatment? So, there's some concerns about that. There's also, and this is going to be a concern no matter who is in office, but there's concerns around equity and access.
Right.
So, you have a new administration coming in talking about, again, trying to gut the ACA, the Affordable Care Act again.
Right.
We'll see what happens, whether or not that does happen. But this treatment could get approved, but if nobody can afford it or have access to it, is that really better than what we have right now?
Right.
Yeah.
Yeah. So it's so many different variables that are unknown.
Yeah. So as far as the new administration goes, we don't really know what's going to happen as far as that goes. But if people are wanting to explore legal avenues of psychedelic use right now, there's still ketamine, which has been here. And then we live in Washington State. Oregon does have a legal psilocybin program that people can go to a psilocybin service center and have an experience there. That is something that's legal. Colorado is in process of getting their program set up.
Also psilocybin, that one?
Psilocybin as well. There are also places outside of the country that offer psychedelics where it is legal. Right. I'm very careful, and I'm not going to recommend any treatment center or any retreat place outside of the country, but I do think there are probably some reputable ones operating and are legal. So people can check those out. I always recommend talk to many people or ask for recommendations who have been there and experienced that before committing to something like that. So that's an option as well.
I feel like one of the themes that you've hit on repeatedly, and I'm just going to restate for the listener, is anything that you're looking into with psychedelics, any experience that you're looking to have, do your research. Do your research. Talk to multiple people about it. Don't just read one website and one brochure and then, buy a plane ticket to wherever. Have conversations, reach out to people, talk to people to people you don't. Figure out what you're getting into as much as you can, because it sounds like a lot of these experiences are deeply unexpected. And so to be able to know the context you're stepping into is huge for that.
For sure.
And then could you speak a little bit to the psychedelic integration groups? Because I know that's a thing that exists. Can you describe what those are and where to find them?
Yeah, psychedelic integration groups, you can Google and some will pop up. There's Psychedelic Support Network. It's kind of like the Psychology Today of psychedelic providers. So you can go on there and search by location, kind of what you're looking for. And you can list on your listing there if you offer integration groups or not. That's a really excellent resource I like to point people to as well. There are also meetup groups that offer psychedelic integration. So I really like Portland Psychedelic Society a lot. They do a lot of, they're an actual nonprofit organization and do a lot of great offerings and work in the psychedelic realm. And they have a lot of free online integration groups run by trained people that are good. Actually, the very first integration group I went to was online with Portland Psychedelic Society. So that's another option you can check out as well. Yeah. And if you go to an integration group, the structure can vary a little bit, but most of the time, it's not really a therapy group. What integration groups tend to focus on is people come talk about their psychedelic experience that they've had. And then if they want, maybe receive feedback from the group, or if the the person has, questions about their experience or kind of wanting to know, is this normal? Has anybody else been through this? It's more supportive. It's not necessarily focused on advice giving or anything like that.
Yeah.
So,
kind of like a community to process through your experiences in. Yeah. Which that kind of echoes another theme that's come up in this conversation in previous ones, which is like, make sure that you trust the people around you who are involved in this. And these experiences can be very transformative on their own. And human beings tend to function better when we have communities that we are tapped into.
Yes.
Our minds are designed to function in network. So being involved in one of those in a situation like that would be important.
Yeah.
Is there anything else that you want to make sure to cover on this like wrap up bit?
The other thing, there are still clinical trials happening.
Right.
So somebody can go on clinicaltrial.gov and look for psychedelic clinical trials that are happening right now and see if they are eligible for any of them and apply to get into those trials as well. If you're looking for a legal avenue to experience these things.
Yeah, that feels very important. Okay. And any updated further learning that you'd recommend?
Yeah. There are some podcast episodes I would recommend. And Tyson, you're going to put them in the show notes.
Yep, they'll be in the show notes.
Two of them are through Psychedelics Today, which I really like that podcast a lot. I think their hosts do a great job, and they have a really balanced approach to who they bring on and how they talk about psychedelics and just the range of topics that they cover as well. So I think that that's a great resource for folks. I also think the book I Feel Love by Rachel Newen is a really great book on kind of the story of MDMA, where it's been and how we've gotten to where we are now. Really recommend that book. I think it's really awesome. Good. Yeah.
Great. You've listened to a rough edit of the first podcast. We've recorded this sort of addendum. Do you want like a final word to a listener who's maybe heard everything you've had to say so far, has heard some of the history, this modality, some of the philosophy you bring to it? Any sort of final thoughts to someone?
Yeah. I will be the first to say that I love psychedelics. They have really impacted my life in a really profound and significant way. And I think I said this in our interview, I'm also a cautious enthusiast. Like I don't think that these are miracle cures in any way, shape, or form. And I think I would be cautious of anyone who is promoting them as some sort of medical cure. I think they can help. I think that they're an amazing tool. I also don't think that they are a silver bullet either.
Right.
So take that into consideration.
Yeah. Kind of a moderation in all things.
Yeah, for sure.
Approach with wisdom.
Yeah.
Well, thank you so much for all of your time that you've devoted to my podcast.
I'm happy to.
And hey, we'll bring you back for season 2 to talk about something else. Very special thanks to Erin Wright. Erin is available for consultation, supervision, and training specifically around the ethical implementation of psychedelics into mental health treatment. Her contact information is in the show notes. Also in the show notes, you'll find links to all of the resources that Erin recommended. I highly encourage you to check out those show notes if you're interested in any of the topics we covered today. I hope that you'll join us in 2 weeks for my interview with Kelsey Watkins on the topic of psychodynamically informed equine therapy. This has been The Way In. This show is hosted and produced by me, Tyson Connor, with music by Ben Lewis and visual art by Dan Lane. If you enjoyed this show, please rate, review, subscribe, follow, like, share, star, heart, reblog, retweet, repost, upvote, or in some meaningful way engage with the episode on your digital platform of choice. I'm told it makes a big difference for exposing more people to the show. And if you think someone you know may like this episode, you could also just tell them about it. You can follow the show on social media, where we are at The Way In Pod. There, you can give me feedback, tell me a joke, and see high-resolution versions of the individual episode art, which I highly recommend. I think Dan did a great job. Thank you for joining us. Until next time.
That was great, Tyson.
Oh,
you feel high?
Thank you. I always feel high after these.
I was like, sometimes I talk about this stuff and then I feel high afterwards. I'm like,
Until next time. Okay, so let me mute my phone is buzzing like crazy. Hopefully there's no emphasis. Oh, I figured it out. My toddler has my wife's phone and is texting me. She does this every now and then. Nice. Mostly emojis.
Yeah.
That's adorable. Anyway, right.